To keep the questions at the end of the presentation, many of them on the coffee breaks and on the dinner. Now we would like to present, and we are very pleased to present Professor Dr. John Schmidt from Zurich, Switzerland, for the presentation of surgical technique of rectal cancer. Please.
Thank you, dear Chairman, Chairwoman, dear audience, for keeping with us late in the evening. Now, my task in the next minutes is to update you on advances in new surgical technique in rectal cancer, and actually there have been quite a few, and I hope that I will give you a good overview of this. And these slides are just to show you that in my former institution I used to work more than 20 years. We have quite a good experience with rectal cancer, more than 1,000 cases, and we have a very differentiated approach to tackle them. Not all of them are radiated. Some of them are radiated, the ones that really need it, and we will come to the controversial issue of neoadjuvant radiochemotherapy later. And of course, most of them are still operated, and I think this will continue to be like this for a while. Surgical mobility is still a problem, as you can see on these slides. Mortality is much less a problem with the improvement of intensive care medicine, but still reoperations occur in every 10th patient. Now, with the local recurrence rate in our entire population of more than 1,000 cases was 4.9%, but that includes also the very advanced cases, including T4 cases. Surprisingly, we had a rather low distant metastasis rate. This may be a selection criterion. Now, ladies and gentlemen, when I studied medicine in the 80s, the best surgical practice was still before TME, and there was a rather frequently cited German multi-center trial at the end 80s comparing different so-called expert hospitals in Germany with regard to the rate of local recurrence. It was a German rectal cancer trial, many of you might know it. And the range of local recurrence between the 8 participating hospitals at that time was ranging between 3%, which was the best one, and 55%, which was the worst one. Now imagine if you have to choose a hospital for your rectal cancer, and it's just by pure luck you happen to end up in the hospital with 55% local recurrence rate. That was really a huge difference, and Bill Hield was the one that really shed light into this problem when he described his TME. And I think now, with these results, almost everybody who performs colorectal surgery should really know that TME is the baseline and the gold standard, and he has to train it. There are many courses all over the world that show how to do it properly, and in Heidelberg we had 3 or 4 courses every year, including Bill Hield, to teach regional surgeons to do TME in a proper fashion. Now that this translates also to a reduction in local recurrence when you introduce TME, the area before TME and after TME. This was shown by this paper by my former chairman Markus Büchler when he was still at the University of Bern in Switzerland, and he compared the local recurrence rate before the introduction of TME. On the left side, group 1 was 20.8%, and after the introduction it went down to 5.9%. So this really had a major impact, and I think there are many thousand people, their lives were saved due to the introduction of this technique. Now, which are the latest changes? At the present time, if the cancer in the rectum is in the upper third, we don't require surgically to do a total mesorectal excision. A distance of 5 centimeters to the distal edge of the tumor is sufficient. So a partial mesorectal excision in these cases in the upper third is okay. But still there's a quite predominant paradigm that in the tumors that are lower down, a 1 centimeter distance to the distal part of the tumor should be maintained. And This topic was investigated by this very nice review, and it was stating the question: is the 1 centimeter rule in distal cancers still state of the art, or can we go even further than this? And this is the result, the main slide of that study that showed if you go below 1 centimeter in very deep cancers, actually the local recurrence rate is not statistically measurable influenced. And you see in the lower part, lowest line, that the confidence interval is still crossing the zero line. So I think there are so many studies in that paper that we can safely tell that if we have a distal cancer and we can we cannot preserve a 1 centimeter margin for sphincter preservation, we can go even lower than that, provided the frozen section during the operation is clean. One technical means to reach that goal is the so-called intersphincteric resection. You see here the sketch of the sphincter region, and this is an intraoperative situation, how this looks like. So you cut essentially the mucosa and the internal sphincter at the dentate line, and then you go in between the internal and external sphincter up. And this, if you use that technique, you can do a sphincter preserving resection in more than 90% of all cases. So only 1 out of 10 APR is still necessary if you use that approach. Now that brings me to the next controversial topic, abdominoperineal extirpation. We just heard in the last talk that this is certainly a procedure with a major morbidity, and if we can preserve some patients for that procedure, that might deserve further investigation. But look at the problem that was coming up, because if you look at APR at the first glimpse, at least the surgeons, when I was still young, we thought, okay, if you do a radical sphincter excision, your local recurrence rate should be very low, because you remove everything, the sphincter and soft tissue around it. So if somebody would have asked me 10 years ago, where is the lower local recurrence? Is it a deep TME? Or is it an APR? I would have answered it's probably APR. But the opposite is the case. And this was brought up by this trial that was examining a large number of APR procedures. And you see that if you do anterior resection with the same stage of tumors, an APR, your local recurrence rate is much higher, with a much higher rate of positive margins than if you do just an anterior resection. And additionally, the rate of perforation is much higher, 13.7% versus 2.5%. So that shows us that APR, it sounds easy, but obviously it's not easy to perform. And the reason for this was highlighted by this Swedish group, mainly by Holm, who presented this paper already a few years ago. And he tackled the problem of APR and the increased rate of local recurrence by explaining it in the following way. You see, this is a classical APR, and you see this is a tailored specimen. So right where the sphincter is approaching the rectum, if you go close to the rectum and then you go wide with the mesorectum, that is exactly the area where the problem occurs. And what he postulated is that you have to... Do we have a pointer by any way? Is that working? Yes. So here's the tailored specimen. And what Holmes said is we have to go all the way up and cut the levator here directly at the pelvic bone edge, and not enter the tissue, the pelvic tissue and the pelvic cavity further down. And this will lead to a non-tailored specimen, which is a so-called cylindrical shape, and this is shown on this graph. So if you cut the levator further up, you will have a much wider soft tissue surrounding of the critical area in the deep cancers. And this is a very logical explanation why if you do this kind of resection of an APR, the Holmes procedure as it's now called, you have a much lower local recurrence rate. But everything has a price because the hole that you have is much bigger. And you need to close it. And you have to close it with the gluteus flap. And this slide shows you the complication rate. It's much on the left side, the so-called extralavatory APE and the standard APE. So they're more radical on the left one. And you see the wound complications is 57% compared to 11%. So it's much higher. But the local recurrence rate is much, much lower. So we think that it is worthwhile to invest this because local complications, they heal completely, but the local recurrence usually is not amenable to any curative treatment anymore. So that this is now really true was that you really preserve life and local recurrence by using the extended APR. The Holmes procedure was just recently shown by this randomized trial from China. And they confirmed essentially the postulation of the Swedish group that if you do an extralavatory APE, there was a local recurrence rate of only 3%, and if you do the standard, it was 13%. But remember, this trial was already designed knowing in your back head that you have to go wider. So I'm sure that the surgeons in the standard group, they were careful that they didn't come too close to the rectums, otherwise it would have probably been even higher than this. Now the next question in terms of surgical technique is the laparoscopic issue. I think I can go quick over this field. There has been numerous randomized trials now showing that the local recurrence and the recurrence overall is not adversely influenced by laparoscopic technique. There's a nice meta-analysis with more than 4,000 patients in 10 studies. But what it showed, surprisingly, is that one issue is higher and worse in laparoscopic surgery, that is the incidence of bowel injury. Not surprisingly, because your vision is impaired with laparoscopic surgery and the instruments you introduce, it can easier happen like in open surgery to do an inadvertent, unrecognized small bowel injury, usually a puncture lesion. So this was a little bit surprising finding, but if you think about it, and every surgeon in the room that is doing laparoscopic surgery has probably in his experience a few cases like this where you have to reoperate 2 days after because of an inadvertent small bowel injury that occurred during the operation due to instrument change. Now, in terms of oncological outcome, I think it is clear that the results are equivalent between open and laparoscopic surgery, but interestingly, the ones that are started laparoscopically and converted to open surgery, the more difficult cases, they have a worse prognosis. So we don't really know if this is due to the conversion itself and due to the time and preparation, and then at some point you decide to withdraw and open up, or it's due to the cancer stage. But it tells us that we should really carefully think before the operation, is that this patient a good candidate for laparoscopic surgery, yes or no? Because if we convert after 3-4 hours because it's too difficult, then the prognosis for these patients seems to be worse. And the 10-year follow-up seems to, it's not statistically significant, but there's some trend. Also, the local recurrence rate for between open and laparoscopic seems to be similar, but another example of the limited vision in laparoscopic surgery is a much higher local recurrence rate in laparoscopic surgery if you do a right hemicolectomy. I mean, if you do open surgery, this is really a very rare phenomenon that you have local recurrence after right hemicolectomy, but 14% local recurrence after laparoscopic right hemicolectomy is a major issue. So you should think of If you have a right colonic cancer extending through the wall, my choice would be open surgery and not laparoscopic surgery. If it's a T1 or T2, of course you can do it, but if it's a T3 or T4, you should probably go for open surgery. Now, what are the perspectives? There's some new developments also in technical nature. One of them is the so-called MENOS. So that is a bottom-up approach for the very deep rectal cancers. I don't want to go into too many details. I think it's for women you don't need it, and for men you only need it. It's a very narrow pelvis, and then you need two teams. So it's quite cumbersome, but it can be done with some good vision. And the results we have to await. And I will not elaborate too much on the neoadjuvant treatment. Just one thing should be mentioned. If we look at the whole population of rectal cancer patients, there are only 5% will develop a local recurrence if they are radiated or not. And 5 of those 100 will be and local recurrence will be avoided by the neoadjuvant radiochemotherapy. So we treat 95 to save 5. And this is, I think, brings up the issue that we should really carefully think of which patients are really taking benefit from radiation treatment and which can be avoided. And I think the trend in most centers is now towards selective neoadjuvant treatment. I want to finish up due to time reasons. In our center, we handle it this way. If the cancer needs downsizing for sphincter preservation, we always do the long course. If the cancer does not need downsizing, we just do the 5x5, the short term, and then operate immediately. And I think this is a reasonable approach. And the early T3 don't receive neoadjuvant radiation treatment because you can achieve an equally low recurrence rate by surgery alone in these cases. So I think for time reasons, I leave it as this, and I'm looking forward to your questions.
Thank you very much, Professor Schmidt, for this elegant